This is the surgical video of excision of squamous cell carcinoma of the abdomen. Lesion was present on the left lower side of abdomen. It was not attached to the underlying structures, and we had done a biopsy which showed that this was an SCC. The suture can be seen from where the biopsy was taken. MRI done to look for extension showed that it was present in the skin and the subcutaneous tissue but was not involving the muscle or the deep fascia. Lesion was marked taking 2 centimeter margins. A flap was designed also in case we needed it, and local anesthesia was injected. Incision was given and we reached the fat plane on all sides. Question I usually ask my residents is, when do you start using diathermy? One should start using the diathermy once there's enough space between the skin margins and the skin will not get burnt by the use of diathermy. We first go through the Camper's fascia, which is the first layer of fat that comes in, and reach the Scarpa's fascia, which is the second layer. This is the Scarpa's fascia being opened, and we reach the deep fascia just above the muscle. Now we use scissors to separate the deep fascia from the underlying muscle very carefully. Going through the Scarpa's fascia on the other side, reaching the deep fascia. Muscle is starting to become visible from this side also. Now, since our plane is pretty clear, just between the muscle and the deep fascia, we use the diathermy here. But at this point, we are making sure that no tumor is visible in the deep margin which we are excising. Clean plane is visible between the fascia and the external oblique muscle. We are also taking the epimysium of the muscle with us so we can have clear margins. Excising the fat and fascia from the other side, we have already dissected up to this point in the deep plane, and here the tumor has been removed. Sending frozen sections now. Small gap in muscle which is seen is the area from where we send the frozen section of the muscle. Excised specimen with markings. We wash the wound and wait till the histopathologist informs us that frozen sections are clear. Then we start closing the wound. Due to skin laxity, we were able to close the wound primarily. A small dog ear is present on one side which we excise, and this is how one should excise a dog ear. The tissue is lifted and an elliptical incision is given along the margin of the redundant skin. Skin and some fat from the redundant area is removed. After the removal of the dog ear, after skin closure with absorbable stitches. Margins were all clear, and this is 1 month post-op.